Good.
Hi.
Welcome
Right.
everybody to our first spring grand rounds for the CUNY School of Public Health. This is the first grand rounds that we hold in this fashion, and in a way it is a reminder of why we are here and why we have this grand rounds. The title of the next phase of the public health response to COVID-19 goals and strategies. With us this afternoon is a friend of the CUNY School of Public Health, Dr. David Nabarro, as well as our distinguished lecturer, Scott Ratson, and our distinguished professor, Dennis Nash, as well as very fortunate to have a recording from this morning by our Health Commissioner, Dr. Auxiris Barbeau, who will appear via a recording that she made earlier today. But first, allow me to introduce our first speaker, our dear friend David. Dr. Nabarro is the World Health Organization Special Envoy on COVID-19, and he's also the co-director of the Imperial College Institute of Global Health Innovation at the Imperial College in London. Dr. Nabarro has devoted his life to the promotion of community-based urban health, including combating pandemic influenza, cholera, and Ebola. He has headed the United Nations response to the cholera epidemic in Haiti, and he also was the special envoy of the United Nations Secretary General on the Ebola outbreak in 2014. Dr. Nabarro was at our commencement as our honorary degree recipient in the summer of 2019. And we are very proud in that regard to call him, perhaps in part, our own. He joins us today from his offices in Geneva to speak about the global response to the pandemic and initiatives related to the next phase of the pandemic. And welcome back to CUNY, CUNY School of Public Health, David, and I'll leave the platform to you.
Thank you so much, Ayman. It's wonderful to be introduced by you in this way, and I really have such extraordinarily positive memories of the time when I came to be able to interact with all the graduates at the commencement address. I want to talk today about the pandemic of coronavirus. And as I do so, I want to, as Ayman said, to talk a little bit more about where we all will be going and where it's likely to take us, what the prospects are, and of course, to focus on the hopes for a vaccine and also the prospects that of a wider immunity to the virus. But let me start with the pandemic itself. It's caused by a coronavirus, and this is a new coronavirus that we've only known about for around 4 months. It appeared, as everybody I think knows now, in Wuhan in China. We were notified about it on the 31st of December. And very quickly it became clear that as well as being a virus that could be spread rapidly between people, it's also a virus that's really extremely dangerous. I don't need to be talking to people based in New York about this danger. And so instead, what I want to focus on is what are the ways in which the pandemic is spreading across the world, and also what action can be taken to contain it. And I want to keep using this word contain, because that is the most important word I believe that we all need to have in mind about this virus and what needs to be done. Just a little bit about the way in which the virus affects populations. Out of every 100 people who get infected and the virus goes into their respiratory tract, about 80 people will only have quite a mild illness, but 20 people will become really quite ill and need some degree of help. And some of them, with that help, will include being admitted for intensive care in a hospital and being helped to maintain sufficient air going into their bodies. But also they'll need to be prevented from death due to complications from other diseases. Unfortunately, around 1 to 2% of those infected, we believe, die. But there are so many unanswered questions about this virus. What we do know is that it's important not to treat it like influenza, because it is absolutely different from the influenza virus. But we also know that we mustn't underestimate it. And perhaps most importantly, we know that if an outbreak starts, it should be contained and suppressed really quickly, because within a small number of days, the size of the outbreak can increase dramatically, doubling in size every 2.5 days, which means if you wait 4 weeks before you take robust action, your outbreak is 1,000 times bigger. And so the task of trying to contain it and suppress it becomes so much greater. We say to everybody, and the World Health Organization has been saying it right since the very beginning, if you have COVID, please get alert and respond as quickly as you possibly can. What is that response? It's not taking medicine. It's not a vaccine. We don't have a treatment for the disease. We do not have a vaccine for the disease. All we can do is what we've always done with infectious diseases, and that is to find people with the disease quickly, to diagnose as effectively and rapidly as possible, and then to ask them to isolate themselves, to keep away from other people, especially for the period of 14 days, and pay particular attention at the beginning of the illness, because that's when people are most infectious. The signs of infection, pretty clear. You get a dry cough, a fever, shortness of breath, perhaps tightness of breathing. I expect many of you watching this have actually had the symptoms of COVID or know somebody else who has. But unfortunately, for a whole mix of reasons, it's often not possible to get a diagnostic test. And that's why people need to isolate just on the basis of symptoms. And it goes beyond that. It's not just isolating yourself. It's making sure that all those you've been in contact with since you had your symptoms, and indeed from a day or two beforehand, they could also be carrying the virus. And you don't want them spreading it so that they lead to a big outbreak. Instead, your contacts have to be isolated as well. And they should get tested if they have symptoms. So that's what it is. Find people with the disease, make sure they isolate. If you can, test. If you can't, you have to do it based on symptoms. Find the contacts, isolate them as well. And very importantly, protect those who are most vulnerable. The people who tend to die from COVID are older people, people in my age range. And the reason why they die is because they usually have other conditions as well, like diabetes, or like respiratory ailments, or perhaps hypertension or other cardiovascular disease. And so we need to make sure that older people are specially protected and looked after. And this is a particular challenge because, again, as many of you know, those who die are often in residential homes, and there have been very high rates of death in those particular settings. Now, the virus moved quite quickly from China to Iran and then to Europe, and then from Europe, it moved on to the US, and it's then moved from the US and Europe back to the poorer countries in the world, and it's now widespread in India, in Africa, in the Middle East, and then in Latin America, in the islands in the Caribbean, the islands in the Pacific, in Canada. It's actually affecting most populations all over the world. Some countries have been able to develop ways of responding quickly and containing outbreaks fast. And they have become able to start really getting very strong defenses in place. Other countries have had to do quite a lot of hard work to reduce the chances for people to be in touch with each other by introducing physical distancing. So and that means keeping 2 meters apart from others. But if people can't physical distance on the basis of their own responsibility, then what countries do is they impose what's called a lockdown. A lockdown means stopping economic activity, stopping social relations, asking people to stay at home. And just at the moment, between 30 and 50% of the world's population is in some form of lockdown. And that has consequences. During a lockdown, we ask health authorities to make sure their people know all about COVID. We ask them to reinforce their community public health services. And that's services that are out in the community where health workers are in regular contact with people so that they can give them advice, they can support them. Also, we ask countries to make sure their hospitals are well able to treat people with COVID, that their health workers are protected with proper personal protective equipment, that they've got masks as well, and that they've got the necessary facilities to treat people. But of course, if the hospitals are not prepared and the health workers haven't got protective equipment, then that puts them in harm's way. So there's a lot of effort right now to try to make sure that everybody who's in contact with people with COVID in the treatment settings does have the protective equipment they need. Now, I told you that when countries do lockdowns, that has consequences. And you've already in CUNY done a lot of work that's shown that the effect of a lockdown is most pronounced for people in the informal economy, for people on daily wages, for people who are poor, because they just don't have the savings to enable them to cope with a period when they can't get employment. And it's a problem in New York, and it's a problem everywhere in Europe as well, and it's a problem throughout the US. Poor people are very, very much affected by these lockdowns. And that's why there's a lot of pressure to try to make sure that lockdowns are as short as possible. But you don't want to release a lockdown before you've got the public health defenses in place, because the virus doesn't go away. In fact, this virus is probably going to stay with us for the foreseeable future. So what you have to do is to use the time of a lockdown to get that public health service back in place, to reinforce it, sometimes engaging community level leaders so that they too can help to keep an eye on the health of people in their area. Indeed, it's really good if there are neighborhood health watches where community leaders know roughly what's happening to all the people in their area so that if somebody gets ill, they can be helped and supported. Of course, it's one thing to say what's got to be done in quite well-resourced places like the United States or here in Europe, in France and Switzerland, where I'm living. But now we've got a whole new problem of people having to cope with lockdowns and to get ready for COVID and to get all prepared in developing countries as well. And there we've got a particular challenge because there are many, many more poorer people who have a great deal of difficulties with getting food. So as well as trying to deal with the disease, we've also got a situation where there's a growing level of hunger amongst adults and children, and also the prospects of malnutrition among children. And that's particularly pronounced because right at this time, it's very, very hard indeed for people in poor communities to access nutritious foods, vegetables, fruits, dairy products, even poultry and eggs. Their supplies have just dried up, and that's because farmers are finding it very hard to get their produce to markets and then to have them distributed on to poor people. So we have this extra challenge of hunger and malnutrition building up. And also at the same time, farmers, particularly farmers with small holdings, are finding it difficult because they've got cash shortage, because they have not been able to sell their produce. And we hear stories in many, many countries of really valuable food having to be plowed back into the land, or if it's fish thrown back into the sea, or if it's dairy produce like milk, just put down the drain. What a waste. And all over the world now, new and imaginative solutions are being developed to get food to people who need it. And farmers are bringing their food, or not bringing the food themselves, but they're getting truckers to bring their food directly to the people who are hungry because supply systems are disrupted. There are other communities that are suffering as well. I've already talked about residential homes for older people. They've got huge problems, especially because their staff often have to be absent because they've got COVID And the last thing they want to do is to bring the infection to their residents. And that means that the residents are getting less care. And in some cases, when they get sick, they can't be helped either. And then we've got the challenge of people who work in particular settings where there are a lot of people crowded together with not much ventilation. So places of detention or prisons are a particular problem, especially as prison staff are often themselves getting COVID. So you've got a shortage of staff, you've got inmates who are extremely anxious and sometimes ill. And you must have heard of the stories of sailors on ships who are getting COVID. And they are often not exactly very well ventilated locations, and they too can be places where the COVID spreads quickly. And then we've heard of people in large dormitories, perhaps they are workers who've come to do construction work on projects, and once COVID enters into a very, very compressed environment, like a large dormitory or hostel, then again you get a lot of COVID, and we have reports from many parts of the world of hostels having high levels of infection. And in very densely populated environments, urban settlements, favelas or townships, we're also getting reports now of extreme difficulty because it's hard for people to isolate themselves if they only live in a family in one house and if the houses are very closely gathered together. So the isolation has to be done sometimes of groups of houses. And that's very difficult, especially if people are feeling anxious about getting access to food. And there have been confrontations sometimes between hungry people who need to be isolated, asking, can we please get some food? And that's putting huge burdens on authorities everywhere. So this is a really tough disease in order to look after. It's hard to interrupt transmission. It's extremely tough when people are having to be confined. And it's really, really tough on health workers when they can't get access to personal protective equipment, and they also don't get access to treatment. And this is the challenge now in many developing countries all over the world, which are facing big outbreaks of COVID and are trying to get themselves organized to deal with them. But we have seen success. Let me just give you the example of Singapore. They were able, through organizing people, improving community health support at the local level, and repurposing hospitals at the beginning to get a very nice situation where they were able to hold the COVID at bay. But then more people came into the country who were infected, and the whole thing started up again. And so they had to, after having lifted their lockdowns, reimpose their lockdowns, and they're going to do it for as short a time as possible and in particular locations in the country to try to get on top of it. And so people say to me, David, what's this going to be like in the long term? Is the virus going to go away or not? And I say, unfortunately, we think this virus is here to stay. We think it's now going to be a new feature of life for everybody. And we're all going to have to be able to find ways to live with this virus as a constant threat. And in order to do that, we have to make sure that every society is COVID ready. And that means that everybody everywhere needs to be able to recognize the symptoms of COVID and know that they've got to isolate themselves as soon as those symptoms come, even keeping away from members of their family if possible. And they've also got to make sure that their contacts have been traced and that they too are isolated. And it's that rhythm of detect, isolate, quarantine, isolate, if possible, test to find out who's got the disease, is absolutely central to being able to interrupt transmission. And if transmission builds up and there's an outbreak, then localized physical distancing has to be imposed as short as possible because it's so distressing, with care being taken to support the vulnerable, particularly to ensure that poorer people get some cash support so that they're not disadvantaged. And just imagine, we have 1.8 Muslim people in the world right now. On the 23rd, 24th of April, Ramadan starts. And for them, this is a particularly disturbing time when they're trying to stock up on food. They do it gradually, especially if they don't have much money, but they are finding it very difficult to prepare for this important period in their annual calendar. And that's what is going to be necessary in this new state as we learn to live with COVID. We've got to be able not only to be able to be on the defense against the disease, not only to make sure our hospitals are strong with health workers that are protected, but we have to build the capacity within our societies to be even more able to support people who have special needs or vulnerabilities to make sure that they don't suffer. This all puts a huge responsibility on public health professionals everywhere. What is the characteristic of a public health professional? It's somebody whose core values are that all human lives are equal, that everybody deserves the best chance, regardless of sex or race or ethnicity or wealth. We're all the same. And that is the heart of public health. That is what we stand for. And what I've seen over the last few weeks is that public health professionals everywhere are coming together in networks. They're sharing what information they have with each other. Sometimes they share information even that is not widely known because they trust in the fraternity and sorority of the public health movement, in that they can talk without fear that they're going to get in any way muzzled when they have things to say. But public health doesn't work in a vacuum. Public health operates in a political context. And so all of us are having to learn to be able to practice public health, even though the political context isn't always on our side. Let's consider the current example that we have all over Europe. Governments are saying this lockdown is hurting. It's affecting our economies. It's disturbing our societies. People are getting frustrated. Businesses are finding it hard to keep going. Some of them are going bankrupt. And so the government says, come on, you public health people, can't you give us a solution to this? We want to be able to restart the economy. We see that our epidemic curves are starting to flatten. Please, let's get going. And the public health people saying, hang on. We really have got to make sure that in all our communities, everybody is ready to be defending against any resurgence of COVID that comes along. We want to make sure that all our businesses have got functional continuity plans and contingency plans, so that if somebody with COVID on the staff is diseased, then we've got to know what we're going to do. What's going to be our isolation strategy? What are we going to do? Are we going to close our restaurants or our shops if it's possible that our staff have got COVID? How are we going to protect our customers? How are we going to protect our staff if our customers have got infection? So all over the world, businesses are working out how they're going to function in the COVID-ready state, how they're going to function knowing that COVID is still going to be moving around. And also the public health professionals are saying, we've got to make sure that all the hospitals are prepared. And so there's a big dialogue now between public health people everywhere and those who want to make sure the economy can get started. And the public health people know that the lockdowns mustn't go on for too long because they know that they're affecting health services for other diseases, and they know that poor people are suffering. And it's that balance that is now right at the center of decision-making in so many countries. And it's an understanding of the political pressures, it's an understanding of people's needs, it's an understanding of the need to get health going, public health services properly set up, that is now a part of a really long and deep political discourse everywhere. But inside all this, I want to go on talking about public health and why this really matters at this time. We have to stick together. We have to continue to work for the values that we believe are right. We have to be recognizing, especially we've got a global focus, that in developing countries right now, with the virus spreading at great speed, there are real challenges, particularly for staff in health centers to keep safe. Testing using PCR to identify people with the virus is really complex and it can't be spread out quickly everywhere. And new virus tests that can be done easily at the point of care, they're not yet readily available. And if we've got an antibody test, that only tells us whether somebody might have been infected some days after the infection started. So it's not really useful for diagnosis. And that's why symptom-based diagnosis continues to be very important. Some people say to me, David, isn't there a cure? We keep hearing of various drugs being proposed as effective cures. And I have to say to them, As yet, there is no proven effective cure for COVID. None. There are trials underway to test whether hydroxychloroquine or chloroquine can be an effective cure, but those trials have not yet been completed. As soon as they are completed, the world will know. There are trials underway for a new series of drugs that have been produced and look very promising. But again, those trials have not been completed. So we do not have an effective treatment for COVID. And those of you who are using various proposed treatments, please remember that they have not been subjected to proper clinical trials, and that's really important. And so others say to me, oh, well, at least those who've had COVID, they're going to be all right. They don't need to worry. I'm saying to them, hang on, we've got reports already from one country that perhaps people who've had COVID and proven to have COVID through proper testing and may go on and get the infection a second time. We don't know whether it's a recrudescence because there was some virus hidden away in their bodies, or whether it's reinfection. And there are some suggestions that perhaps the immunity after a COVID infection is not necessarily strong immunity. It's not necessarily going to protect you from further infection. There may be some that do develop immunity, but there may well be others who do not. After all, this is a coronavirus, it's a new coronavirus, and it's full of surprises. And by the same token, there are colleagues saying, oh, well, there will be a vaccine very soon. We hear that there are already candidates available and being tested. And I want to salute all those who are researching for vaccines, who are working night and day to develop candidates. But we also know that before you can have a vaccine that's available for the population, it has to be tested in a rigorous way for safety and efficacy. It has to be shown that it can work and provide proper immunity. And it has to be produced in large quantity and made available for distribution. And we want to be sure that when it's distributed, it gets to the people who most need it. So a really robust global distribution system will be necessary. And that will take at least 18 months and quite probably longer. So we're going to have to be working to be COVID ready and defending ourselves against the virus and able to respond to their outbreaks without hospitals being overloaded by rapid and robust action as soon as cases appear for the foreseeable future. Some people have said to me, well, okay, governments are changing their guidance a lot. Doesn't that make you feel that perhaps governments don't know what they're doing? I say to them, no. Governments are changing guidance because new evidence is coming available all the time. And that's actually as it has to be, because this is a new disease. So don't get frustrated if you get different information after a few days from your government or from your local health authority, because that may well reflect changes in knowledge. For example, we know that there is a number of people in society who get COVID without having many symptoms. There may even be some, again, we don't know how many, who may be completely without symptoms at all. So that means they could be transmitting the virus and not knowing that they're doing so. How do we cope with that in society? I think that in the COVID-ready state that we will have to adopt, as long as this virus is threatening us, we will pay much more respect to physical distancing. We will try wherever possible to keep 6 feet apart from each other. This will mean that we will probably not want to go to gatherings unless we know that everybody else who's coming to the gathering is being super responsible about their health and well-being. Again, that's as it should be. Some of us will feel that we need to be able to protect ourselves. And so we will be very fastidious about hand washing. We'll be very careful about how we cough. We will be very careful if we've got illness. We may want to wear a face protector to try to reduce the risk that if we've got the virus, we will pass it on to others, or if we haven't got the virus, that we're less likely to get it. Of course, the effective face protectors, N95 masks, really need to be reserved for health workers. There's a shortage of them, global, and we're trying very hard in the World Health Organization to increase supplies. but it's super difficult because everybody who's got a mask is holding on to it for dear life. They don't want to give them up in case they might need it. And so we've actually got stockpiling of masks occurring in many, many places all over the world. And yet I'm in contact with health workers in poor countries who are saying, please give us masks. Please let us have them. We can't buy them. We can't get them anywhere because of the shortage. And so I'm saying, if you are not a health worker, if you're not somebody who's got COVID, if you're not somebody who has to be in contact with people all the time and is worried about getting the disease, please don't use an N95 mask. But if you want to protect yourself, follow the advice of the US Surgeon General and make your own mask, but make sure it fits well, because a well-fitting mask can be a useful protector, but a poorly fitting mask is not really very good at all. People say to me, well, if you're wearing a mask, you might actually increasingly touch your face, and that can actually be an unfortunate thing. So I'm saying you should do your best to please make certain that when you're wearing a mask, you practice good hygiene and you do not add to the risk. Last point. The world needs an organization that is the place where public health professionals come together and where they are able to share without fear what they suspect and what they're seeing. That's the World Health Organization that I'm proud to represent, that I used to work for. Without the World Health Organization, there's no place where we can work together. Of course, the World Health Organization is owned by 194 governments, and they spend a lot of time debating how the World Health Organization should work. They set the rules for what the World Health Organization should do in relation to infectious diseases. There's a thing called the International Health Regulations that was negotiated in 2005. Under those regulations, the countries are asked to inform the World Health Organization if they decide that people from a particular country or countries may not enter their own borders. That's the International Health Regulations instructions. And when a country decides that certain people may not come in, they are required to inform the World Health Organization Secretariat of decisions they've made so that other countries can know what's been done and why. That's a global treaty. That's a global instruction. That's not the decision of the World Health Organization Secretariat. And the World Health Organization relies on information that it receives from countries. It's not a World Health Inspectorate. It's an organization that relies on information received from countries, all countries. That's how it's always been. And until the rules are changed, that's how it will be. So within those contexts of agreements that have been reached between the governors of the World Health Organization, we do the best we can, and us public health professionals try to interpret the information we receive. We try to be fully honest, because there's only one thing that we stand for, and that is for the health of people everywhere, regardless of who they are, where they live, how wealthy they are, their ethnicity. That is our motto, that is our creed. So thank you very much indeed for the time to speak. If I can't stay, it's because just at the moment, things here in the vicinity of the World Health Organization are surprisingly busy. Thank you very much for the chance to talk to you at the beginning of this session.
Thank you, David. And it's not lost upon us that the icon of the Sustainable Development Goals is right behind you during this presentation. And there isn't a moment more poignant for us to understand how important these goals are and how we need to keep our eyes on the target during these difficult times. Sometimes when things are quiet and everything is all right, we forget the importance of these goals. But during moments like this, and based on your presentation, we are reminded that, as we say in words, truly not always in action, we are in this together. Thank you. We couldn't have had a better opening. You will always be a friend of CUNY School of Public Health. Thank you again. We move from this wonderful presentation that gives us this important global perspective to something different. Our next presentation is by our distinguished lecturer, Dr. Scott Ratson, who joined the School of Public Health in the last year. He is also the founding editor-in-chief of the Journal of Health Communications, which is now housed at our School of Public Health. He brings with him 3 decades of pioneering accomplishments domestically and globally in health communication, health literacy, and strategic diplomacy. Scott was recently Senior Fellow at the Mossawa Rahmani Center for Business and Government at the Harvard Kennedy School, where he published Guiding Principles for Multi-Sector Engagement for Sustainable Health, and a series of published articles related to vaccine communication. He will speak today about vaccine acceptance based on a survey that the CUNY School of Public Health is conducting on 1,000 New Yorkers, but also based on his very long and deep experience in the field. Scott, welcome to the podium.
Oh, thank you very much, Dean. And I'm particularly honored to be a member of the faculty here at CUNY, as well as follow David Navarro, who gave such an inspiring speech and presentation for all of us to be honored to be public health professionals and hold those values that he so inspires. So as the Dean mentioned, I'm going to go through a study that we've done and talk about vaccines and vaccines and what they mean amongst the COVID situation. So the screen should be on of my title slide. And as we have for the grand rounds here today, what is the next phase? What are goals and strategies? And I'm going to spend about the next 10 minutes to go over some of the areas that I think are most important for us to consider, as David well said, a COVID-ready society and living a new world, or the next normal that we're going to need to define as public health professionals. So this is one of the pieces that I remember from the very beginning of my training in health communication, that our goal should be to have informed opinion and active cooperation on the part of the public, as these are the utmost importance in the improvement of health of the people. While this was the WHO's preamble in 1948, still today, how do we get the world engaged in developing activities that give the competence for them to make better health decisions at all levels? So what we set out to do here at CUNY is a tracking survey, and with the dean and a research team, we set out a goal that we thought it would be important to look right in our backyard. And at that point, we didn't know we would be the epicenter of the world in terms of this COVID-19 epidemic, but we thought we needed to see what knowledge, attitudes, perceptions, behaviors, and issues were on the mind amongst New Yorkers to inform better decision-making for public health and better policy making. And let me first say that we say New Yorkers, we did both a survey of the state and the city, and we had a representative sample that we've been running for 5 weeks now of 1,700 New Yorkers. We've been continuing to show the importance of this with weekly snapshots with different questions that are rotated in on the economic fallout, on who people trust, and what behaviors people are adopting. As noticed, we're at March 13th is when we started it. Tomorrow will be week 6. We conduct the survey Friday through Sunday with online, text, and phone in both English and Spanish. We analyze it beginning Sunday afternoon and get the information out for publication on Tuesday. So as Professor Dr. David Navarro just said, and others, we continue to know that the world will not be the same with, as he said, testing, but down the road, we hope to have a vaccine. Dr. Anthony Fauci said this at the White House briefing: the showstopper will be a vaccine. And I quote Dr. Navarro, what he said on Meet the Press on Sunday: we are not so sure as it will come in waves that influenza does. We think it's going to be a virus that stalks the human race for quite a long time to come, until we all have a vaccine that will protect us. And I think the words that he said today were particularly saying it's a feature of life for everybody. So we have to move it from stalking, which is negative, to the COVID readiness, which is, I think, what we've been talking about here. And the second part of this will be going from goals to the data, and then finally the strategies. But what if this vaccine that we're all hoping for, 70 candidates that are out there, according to the latest count. What if it's developed in record time and only we find out that the public is less eager for it than policymakers or public health officials, that people don't want to get the vaccine? So we sought to provide some data and asked these questions a couple of times in the last 5 weeks. And in short, I'm going to last weekend's poll on Easter Sunday, when we analyzed the data. The first thing we asked, or amongst the other questions, when do you think the vaccine against coronavirus will be available? And a quarter of the people about thought it would be fairly quick. But you heard from David, you've heard from Tony Fauci and others. It's likely to be 12 months if we are lucky in the best case scenario. And more of the dialogue is going to a longer period of time, as David just mentioned, 18 months. So people seem to have some understanding, although a minority, that it will be some time. But the part that's in green is the challenge and the trouble that we see. If the vaccine were available, would you want to get vaccinated? And just over half of the population in New York City said yes. This is at a height of an epidemic, when they have fear, when they have knowledge of people that are getting the disease, when hospitals are being swamped. So this really shows that we have an issue that we need to understand and figure out how to address this. So we also asked this question, as we break this down, by race and ethnicity. And what's also challenging here is to see the disparity. The fact that the Latin population is amongst the lowest that we found last week is quite concerning, and is for a variety of different reasons. It could be knowledge, it could be access, it could be immigration status, a lot of different pieces that we don't necessarily understand at this point, but the numbers have a clear signal that this data is something we have to look out for. And even at the height of the 73 and 71%, we're hopeful that even if every person would in fact have a vaccine that was safe and efficacious and so forth, that still may not be enough for herd immunity, as we just heard from David and others. So we asked people also in this survey a qualitative answer. If not, why not? And these are just illustrative, but it's very similar to data that has continued to be found by Heidi Larson, who runs the Vaccine Confidence Project at the London School of Hygiene and Tropical Medicine, that these are some of the 4 areas, trust being one of the strongest ones in terms of the challenges that we face, but also the other ones. And while these are just illustrative, we know that people are refusing, they don't like vaccines, they're concerned about safety. And some people even on the safety piece think if we rush to have a vaccine, that will make it less safe. So they want to see how it is first. You can superimpose that with some of the cultural and anthropological ways that people in the United States look at new products. Vaccine literacy, people don't understand how a vaccine works, vaccine prevention, and the preventative nature of both adult and childhood vaccines. And then the distrust. And unfortunately, we continue to see, as I mentioned, Dr. Larson's work, we continue to see this trust erosion, also frankly coming from different parts of the US government in science and medicine, to also find their way into how people will make decisions based upon their health, and vaccines in this case. So this is not just a US phenomenon, although the US seems to be worse by our latest data. This is data that is continuing to be collected at the Vaccine Confidence Project. And just as you can see, Australia, which was just a couple of weeks ago, is actually trending upwards, where they're at 87%. France at 70%, which is a large number of refusers. So when you see the 18% is actually a strong negative response that's consistent. The United Kingdom and Austria. And this is just meant to be illustrative that none of these would be at the level that we would like to see at the height of an epidemic. And while this is happening, the anti-vaccine folks that are also contributed to the distrust or the mistrust or the disinformation continue to turn up the volume. Some of this was highlighted in the New York Times a couple of weeks ago, but also Mother Jones in the last week, a fake pandemic, anti-vaxxers are spreading coronavirus, MedPage Today, Undark, and even in CBS. And this is just mass media reporting on this, but we have seen spikes in social media and other posts and other shared pieces that are showing that people are already doubting what we might have as the only antidote in our arsenal in 2020 and hopefully 2021 to begin on vaccination. So what does this all mean? I suggest we know what to do. And in 2014, I actually wrote something when I was on the CDC Board of Scientific Counselors for Infectious Disease, that we knew what the key to containing Ebola was. Now, Ebola was much more obviously confined. And for those of you who know the infectious disease part, it was much more efficient in that it didn't spread quite the same way. But the same answers of what we had then is what we need to do now. On the left, we say to modify behavior requires direct, open, understandable, and timely information from a single authoritative source, as well as providing intermediaries with the tools they need to reinforce the message. Whilst there may have been some criticism early on, the WHO, as David mentioned, the 194 member states that are part of it, did coalesce around the WHO, and with the help of a number of member states, did have an authoritative source. And we have been able to at least reverse the scourge. That doesn't mean it hasn't been solved, and there certainly are outbreaks, but yet there is a way to contain Ebola, and we were successful in that regard. Those of us at the National Academy of Medicine, I'm on the board of Global Health, and we talked about this at the meeting, and after that meeting, a number of us wrote a very quick call for coordinated action, again on trusted sources. And again, we know what to do. COVID-19 is a test of the global health policy's credibility in addressing a legitimate public health threat with an unknown trajectory. This sort of emergent threat requires government, media, technology platform, and the private sector to step up. Later in there, we called for, again, an authoritative source. And still today, I think whether you look in the United States or you look at other countries, we've been told we have yet to have the source at the level that we need to transform the necessary behaviors. And let me say that David articulated Dr. Navarro in such an amazing way that if we had rhetoricians and people speaking on this level throughout society, we all would be much better off. And that is something, again, that inspires me in the field of public health and on the faculty at CUNY to do this both with our students and colleagues. So finally, what can we do to be COVID ready? I put David's term right in there. We need to think already to be strategic about vaccine acceptance for COVID-19. We have to start with vaccine literacy when we go back to school, not only schools at the grade school level, but throughout society. When we go back to the workplace, while it's in development, what will this mean? What will this change? We still will need to have protective behavior. We'll need to begin to talk about the ethical nature, just of who should have the N95 masks, who should be the first ones to get the vaccine. How do we really combat anti-vaccine propaganda? Can we shut down, or should we shut down, Facebook and other communities that are propagating what's bad for society as a whole? How do we limit the negative role of social media and develop the proactive measures with traditional and the new media? How do we optimize search engines? Google, all these groups have a role, and new media includes what's within arm's reach of everybody. How do we get the information that we can use and not overstep privacy and other issues that are also fundamental in the equity that we hope to strive for with public health advances? And then how do we elicit those of us in public health, healthcare professionals, and key influencers to advocate for vaccination and for the appropriate public health measures? And while we're doing that, we can't forget we have a stoppage right now in some preventable vaccine diseases. Here in New York, we had issues with measles outbreaks, and we still have those pockets throughout the US and globally. We need aggressive catch-up campaigns for spots on childhood. We need to think about how we even get vaccine coverage up in the United States for seasonal flu and others that can protect against cancer, such as hepatitis B, and human papillomavirus. And finally, papillomavirus. Finally, other vaccinations that continue to be added in our lifespan. So that's where we are. My final slide is there can be a pie in the sky that we have a vaccine literate society. Can we protect against this vaccine, which is named, with this virus, which is named SARS CoV-2? How do we create a vaccine literate world? How do we inoculate society? And how can we support a community immunity which is what we want, which is not just herd immunity. It's broader with the kind of community work that we all are trained to do, that we can do, and that we can inspire others to be part of the community with effective communication. So that's my hope. We have an acronym that we're in the works of civic. So it's both a civic duty, but how do we coalesce, whether it's around a coalition for informing vaccination internationally on COVID-19, how do we coalesce this multi-sector initiative to provide for a better world? And those of us at CUNY School of Public Health and Health Policy are dedicated to do that. We'll have more information and data with the surveys that are ongoing. And then again, thank the Dean and others who've been part of this for both the foresight, for the engagement, not only with grand rounds of opening ourselves up to the world, but also to how we hope to have an evidence-informed society with an ethically driven approach of public health, which we're all proud to be part of. So thank you. Back over to you, Dean.
Thank you, Scott. A lot of questions are coming up for you to be able to answer at the end of the session regarding to vaccine acceptability by age group and by level of education. So be prepared for some of these responses later.
Okay.
We are very, very lucky to have Dennis's time today. Dennis Nash is our distinguished professor of epidemiology at the School of Public Health and also the executive director of the CUNY Institute for Implementation Science and Population Health, housed at our school. He's an epidemiologist with over 20 years of experience in conducting epidemiological studies, and his central interests include infectious disease in the field of public health surveillance. And he has worked extensively domestically and in international settings, conducting large-scale, real-world studies examining key outcomes amongst especially persons with HIV infection. He just sent me his title, which is Epidemic Intelligence to Inform the Public Health Response to SARS CoV-2 Pandemic, and the podium is yours now, Dennis.
Thanks, Ayman. I hope everyone can see my screen and title slide. If so, I will get going here. Yes, so the public health response, indeed, an integral part of the public health response to the COVID crisis really should include all of the things that Scott and David Navarro talked about, but also critically the dissemination of timely dissemination of common goal-aligned metrics. This is sometimes neglected and sometimes hard to pull together quickly in emergency responses, but it is really important to have a well-chosen, thoughtful set of metrics that are aligned with the goals of the response. So there are many goals to the public health response, and I'm choosing here to focus on about 3 of them here for the purposes of this metrics discussion. But I would say there are 3 key goals: mitigate, suppress, and control community transmission of the virus. Goal number 2 would be to prevent or minimize morbidity and mortality from COVID-19 disease. And goal number 3, as we've heard, it's critical to protect the healthcare workforce and other essential workers from becoming infected with SARS CoV-2. So I'll just go through each of these 3 goals and give you a sense of some of the metrics that I think have been useful so far and can be useful if we were to sort of begin to think about adopting them as common metrics and disseminating them widely. So goal number 1, mitigate, suppress and control community transmission of SARS CoV-2. We do need some kind of proxy for incidence. We can't go out and measure every new infection that's happening in the general population. As we've heard, there are many challenges. Some are asymptomatic and some are mild disease. But we can use proxies. And we've also been challenged by the limited availability of testing and how testing is being used. And so that's not always a good reflection of trends in transmission or spread. But we can turn to things like the number of COVID-related hospitalizations and deaths. These can be a good proxy to infer trends about what was going on with transmission maybe 5 to 15 days earlier. I really like the example of New York City's syndromic surveillance data shown here. Year-over-year trends in emergency department visits for influenza-like illness and pneumonia, and then also admissions to the hospital from the emergency department. You can see here this daily data was very sensitive and picking up a pretty sharp increase in visits and admissions to the hospital in early March. So this can be helpful as an early signal to what might be going on. And you can see this is sort of dwarfing what was happening with flu weeks earlier. Another metric on the right here is the number of people admitted to the hospitals all across New York City for COVID-19 like illness. And the City Health Department has shown this trend, which is a good trend in terms of its going down, but we want to be well below this line of 200 hospital admissions per day in order to, as we heard before, manage the ability to absorb surges in the healthcare system of more COVID-19 like illnesses. Also, it's really critical that jurisdictions should track the number of outbreaks that are happening in congregate settings such as nursing homes, jails, prisons, assisted living, and adult care facilities. I'll come back to that, and we heard about that earlier as well. Importantly, that same syndromic surveillance data I showed you earlier, the City Health Department has begun disseminating it every day, this time broken out by age group. And so here you can see hospital admissions from the emergency department, the trends that have been happening. Again, here, increases, of course, in age groups above age 18, and the sharpest increases among those age 75 and older, but we're beginning to see some of the declines in those increases in hospitalizations for influenza-like illness and pneumonia, which is a good sign. With regard to goal 2, preventing or minimizing mortality and morbidity from COVID-19 disease, another metric that the city has put out that I think is useful here on the left is showing the daily number of people who are in critical care across New York City health and hospitals. They don't have a target for where they want to be here, but clearly this is something that we need to keep as low as possible. And also tracking the lab confirmed cases of COVID that are fatal. And these data have shown and highlighted some of the very concerning disparities that David Navarro alluded to earlier that are happening in New York City with very vivid example of health disparities, and I'm sure in many other places around the US and the world as well. We don't have in New York City the ability to, right now, to track what's going on in nursing homes, but Connecticut today just released something which I think is very useful in terms of metrics by nursing home and by town, the number of licensed beds, the number of residents with COVID-19, and the number of deaths. If you go through all of this table, you can see this is a very vulnerable population. The case fatality rate in nursing home populations in Connecticut is around 22%, so 375 deaths among the 1,700 or so COVID diagnoses. And then we also have seen, the mortality data that's been coming out and trends in death on the decline finally for both confirmed and probable COVID-19 disease. This is New York City data shown here. In New York State, as I mentioned, the data are limited, but they are reporting at least the number of deaths that are occurring in nursing home facilities and adult care facilities. It's quite high, 2,400 deaths in nursing home facilities across New York State. We don't have a sense of what the denominator is, so I can't give you equivalent statistics there, but I'm sure the death rates are equally high and concerning. Goal number 3, protecting the healthcare workforce and other essential workers. We really need to be thinking about how we can track routine health screening and testing of all frontline healthcare workers, first responders, and tracking of absenteeism and death and things like that. There are not that many good data and metrics out there right now. There was an MMWR that CDC put out the other day. Among all the cases that were reported to them nationally, about 315,000 SARS CoV-2 cases reported through April 9th, only 50,000 of those reports indicated whether or not the person was a healthcare worker. And so among the few states that were reporting it consistently, healthcare workers corresponded to about 11% of all reported cases. And you can see here that these healthcare workers are being hospitalized, admitted to ICU, and dying as well. But these healthcare workers and other first-line responders and essential workers are critical for us to get through what is going to become a new feature of life, and we need to be sure that we can protect and take care of them. And you're seeing some of the results of the lack of feeling like there's a lack of concern for the health and well-being of our healthcare workers and other essential workers, and we need to address that. I also want to talk about, in addition to some of the goal-aligned metrics that could be disseminated routinely publicly, some other key epidemiologic questions to inform the public health response. And we've heard this alluded to a little bit earlier in David Navarro's talk. What is the impact of the non-pharmaceutical interventions on the incidence of infection, on the incidence of disease and of deaths? And what will be the impact of relaxing some of these non-pharmaceutical interventions on these outcomes? Also, important unanswered question, or not fully answered question, among those with SARS CoV-2 infection, what proportion are asymptomatic? And finally, among those who have recovered from SARS CoV-2 infection, is there protection against reinfection and/or development of subsequent severe COVID disease? So I just want to say about what we're doing at the CUNY Institute for Implementation Science and Population Health to address this. This is a study that we launched on March 28th. At the time, there were about 466,000 cases and 7,000 deaths in the US, where we've reached out to people on social media, through Facebook and through Instagram, to enroll in an online cohort study a longitudinal cohort study that we are running. And they could join the study through our website, or they can join by clicking through on some ads on social media. And we recruited through these mechanisms. Since March 28th, we've enrolled about 5,900 people across the US, and you can see the distribution of enrollees into the study by county here. So in just about 3 weeks, we've enrolled over 5,000 participants. And if you look at the map on the right of the new diagnoses in the US, the map of our participants in the Chasing COVID cohort overlay pretty well with the number of SARS CoV-2 cases. So we've enrolled people that are in affected areas, pretty well matched. What does our cohort look like? These are some of the distributions of variables from a few days ago. They tend to be on the younger side, and they do have a fair number of comorbidities. Many have seen physicians and sought healthcare for symptoms. Many are healthcare workers themselves, and we've also begun to get some information on the kinds of non-pharmaceutical intervention behaviors that they've been engaging in. And here you can see state by state, the kinds of enrollment that we're getting. Some of our biggest states include places like California, New York, Texas, Florida, Pennsylvania, and Illinois and Georgia. What are we asking them about? On the baseline survey, when they first enrolled, you can see some of the different realms of questions that we've asked about, and I've presented a little bit on this. We're about to do our 1-month follow-up interview of the Chasing COVID cohort participants, and we'll include some other questions on here, including whether or not they have issues related to food and housing security, mental health, social support, interpersonal violence, and questions around substance use and problem drinking, for example. These are all things that have been raised as concerns about some of the potential negative impacts of non-pharmaceutical interventions that were alluded to earlier. We have taken our cohort and the work that we've done to date and developed a proposal to NIH. We responded to the notice of special interest, or the NOSI, call for proposals at the National Institute for Allergy and Infectious Diseases. And we've put in a proposal that we would add serologic testing to this cohort so that we would be able to mail dried blood spot testing kits to people's homes, so they wouldn't have to leave to get tested. They could send those back to us in the mail, and we could then look at the results and send them back to the patients and examine them in our cohort. We've done a very small pilot in our cohort, and you can get a sense of what the kits look like when they come to you in the mail, and where the dried blood spots are provided by the participant. And so we put together the following scientific aims in our proposal to NIH, which I think line up well with some of the unanswered or epidemiologic questions that really need to be addressed and improved with more rigorous evidence. We will rapidly estimate the cumulative incidence of SARS CoV-2 infection using the serologic test, and evaluate the effect of different non-pharmaceutical interventions on the incidence of these outcomes. And then we will also, because we're following this cohort longitudinally, be able to evaluate the impact of relaxing these non-pharmaceutical interventions when that begins to happen. We will also rapidly estimate the proportion of persons with serologic evidence of SARS CoV-2 infection who were asymptomatic or had only mild symptoms. And finally, we will rapidly assess whether or not SARS-CoV-2 antibodies are protective against subsequent COVID disease. These are, I think, very important questions to help inform the public health response, to get at some of the unknowns that Scott and David alluded to a little bit earlier, as we begin to move on to deal with this new feature of life, namely SARS-CoV-2. So I'll just stop there. I know that there's time for a panel discussion, and acknowledge some of the people that helped this work take place. Thank you.
Thank you so much, Dennis. We need to move on to a recorded segment that we received from our Health Commissioner, Dr. Roxidis Barbeau, and she is addressing some of the decisions to be made in the next few weeks, which is on the mind of many of the audience, I'm sure. Dr. Barbeau is the Health Commissioner of New York Department of Health and Mental Hygiene, and she most recently served as the first Deputy Commissioner and oversaw development and implementation of agency priorities, including Take Care New York, the city's data-driven health agenda focused on addressing the social determinants of health and engaging communities on the issues of health equity. Dr. Barbeau has over 25 years of experience in advancing health equity and providing healthcare in urban communities. She is a very dear friend, and I would say, if I could be allowed, a former student and a colleague of mine. I hold her in the greatest esteem, and I'm very, very excited that she was able, despite her very hectic schedule, to record these remarks for us today on the epidemic and its impact on New York City. So from here, we move to her presentation. I want to assure the participants as to if we have enough time to respond to your questions, we will live, but also we will post answers to your questions on our website under that title, Responses to Questions on the Public Health Rounds, if we don't have time to answer them directly. And now we move on to Dr. Barbeau's comments for today.
Sound is not working.
No, I can't hear.
Opportunity to Good afternoon. I'm Dr. Oxidis Barbeau, New York City's Health Commissioner. I want to start off by thanking Dean Almohandes for this invitation to participate in Grand Rounds. And I want to apologize for not being able to do this talk live, but I wanted to take the opportunity to provide you an update on where we are with regards to COVID-19 here in New York City, and to give you a high-level overview of where our response is headed. And so I want to just give you a sense of what I'll cover in the next couple of minutes. So I'll go over where we are with regards to the epidemiology. I will go over some of the public health indicators and milestones that we've identified as positive signals of progress in regards to mitigating the spread of the virus. Then I'll talk about current and next phase of our response. And then lastly, talk a little bit about our role in ensuring recovery from this pandemic, and specifically recovery for communities that have suffered the most. And so let's begin with where we are as of the 16th of April in terms of the number of cases. And before I go into more details, I want to first start off by ensuring that all of you are aware that all of this data is available on our website, nyc.gov/health. And I encourage everyone to look at that data on a regular basis, because the information changes daily, and we are also adding more data as we speak. And so the chart that you see before you represents all of the cases that have been confirmed by testing done either at our public health lab or through the commercial labs throughout the city, as well as our hospitals. And so I think it's no surprise that the number of cases that we continue to see goes up, and that currently we are at over 100,000 individuals in New York City that have tested positive for coronavirus, and many, many more that are likely to have been exposed and have developed illness because of COVID-19. This next slide is an indication of the number of people that have ever been hospitalized, either in our public hospitals or in our private hospitals, from March 2nd until March 16th. And again, just to remind all of the trajectory of this illness, by and large, roughly 80% of the individuals who do contract COVID-19 do not require hospitalization, but those who do require hospitalization tend to hover around 20%, and that's what we're seeing in our numbers. The next slide that I want to just go over is a very sobering slide, and it's the number of individuals who have had either confirmed by a test or probable by indication on their death certificate, the number of people who have died thus far in our city. And it's a number that gives us pause, because clearly it is a number that I think to date would have been unimaginable. Sorry, I stagger on the word itself, because it is just really a reminder of how vicious this virus is and how it is a formidable enemy that we are all fighting against, and that it takes all of us, not just public health, but healthcare system and every single New Yorker, to ensure that as we adhere to shelter in place and covering our faces with coverings when we have to go out, that we do so to save lives. One of the things that I will highlight about this data is that we are one of the first jurisdictions that is reporting on this data. There are a number of states that have done so, but it's not, by and large, all of them. You know, this is part of our transparency in the data and describing how this pandemic is affecting our city. But it's also, as I've said in several other situations, part of the transparency with regards to how it is that this virus is affecting our community. And, you know, as the days go on, there will be, I'm sure, more information that we will share in terms of the outcomes from this virus. This next slide is a little bit busy, but I want to just highlight a number of things on here. One is that it's really one of the first times that we, as an agency, have released data before it's complete. And this is a table that shows the breakdown of deaths by race and ethnicity. But I draw your attention to the fact that this chart only has 63% of the deaths complete for race and ethnicity. And it's an indication of, I think, a number of things. One is how rapidly this is happening, and the fact that while funeral directors and providers have anywhere from 24 to 48 hours to 72 hours to fill out this information, that amount of hours means lives in this response. And we felt a responsibility to share that information, even though, again, it's not fully complete. We are putting tools into play that we have never used before with such speed, namely tapping into RIOs, tapping directly into electronic medical records to maximize the number of data that are complete for race and ethnicity. And I think that this is, after all is said and done, perhaps one of those things that we will all redouble our efforts in ensuring that both hospitals and laboratories and all of us are more complete when reporting race and ethnicity, because even though we know it has no biologic basis, it has everything to do with the way in which the social determinants play out. And what you're seeing here in this table is that, by and large, people of color, Black and brown people in this city, are dying twice as fast as white New Yorkers with regards to this virus, and that it speaks to the acuity with which the underlying social determinants of health that have been embedded not only in this city, but in this country are really playing out. This next slide, I want to talk about the milestones that we have identified in determining when we are close to lifting some of the mitigation strategies that we have put in place, and the degree to which we have been transparent with New Yorkers about looking at three broad categories of indicators with regards to hospital admissions, to our critical care capacity, and to the distribution of positive test rates across the city. And so this first indicator looks at the number of hospitalizations for COVID-19-like illness. And this is an indication of what we see across the city. Currently, we are not where we want to be. And the goal is to have this indicator be consistently below 200, which is our baseline, and have it be such at that baseline for a period of 10 days. This next slide looks at the daily number of people in critical care across our public hospital system, the health and hospital system. And this is an indication of the number of people that require intensive care support, that require ventilator support. And truthfully, this is not an indicator that we have as a city needed to look at in the past. And so we are actively working with our partners at Health and Hospital to determine what threshold, what guidepost is the most reasonable one for us to ensure that when we get there, it's the right one. Because again, this speaks to the capacity that we need to have in our hospitals for when and if, not if, but when we lift our social distancing measures. I think it's inevitable that we will have some measure of rebound, but we want to make sure that our hospital capacity is such that it can then absorb any potential resurgence. And then this last indicator, which is actually composed of two indicators, is the testing positivity rate at the public health lab. And I'll remind you that that is a measure of positivity for people who are already in the hospital or about to be admitted. And that the lower line, the all New York City testing, is what the positivity rate looks like out in our communities. And again, we want to meet these guideposts for consistently for 10 days as an indication that it would be a reasonable time for when all of these indicators together have maintained that status for 10 days, that it would be a reasonable time to start lifting social distancing measures. And so currently, these indicators haven't met those guideposts and we haven't met those timelines. And so we are still in the mitigation phase, and we're still in the phase of reserving our healthcare capacity, both by bringing in more volunteers, by opening up alternative care sites to ensure that any New Yorker who needs care has access to it. So that being said, we know that there are parts of our city that are being disproportionately affected by the impacts of COVID-19, and we are actively rolling out as well as developing an equity action plan. I think that many of us in leadership have said this throughout this response, but this is a clear situation where we are building the plane as we are flying it. And so some parts of this equity action plan have already been implemented and already are out in the community, and some of these will be rolling out over the next couple of days. And so I want to then start by highlighting the fact that we are focusing on 88 zip codes throughout the city with the highest indication of not only transmission, but poor health outcomes. I have recorded a message to New Yorkers that live in these 88 zip codes, reminding them about COVID-19, reminding them about the need to shelter in place, and giving them information about where to call if they are one of those people who have chronic underlying illnesses or above 50 years of age and are experiencing symptoms or are caring for someone who is experiencing symptoms. I think one of the things that has been very clear is that while we are blanketing the airwaves and while we are blanketing all available media outlets, we can't take for granted that this message is reaching all of our communities, and we have to do that much more to ensure that we are reaching communities that are at highest risk for poor health outcomes. We are reaching directly into their homes by these robocalls. There will be more targeted media in communities, and we're doing this in anywhere from 15 to 25 languages. Over the course of this response, we're going to be targeting grocery stores, bodegas, subway stations that may still have relatively high usage rates. Beyond that, we are also partnering with our community-based organizations to have them amplify our message. We have partnered with our faith-based organizations, and then this past weekend, many of them have incorporated into their sermons messages about COVID-19 and the importance of staying home as a way to save lives, and the importance of seeking care when individuals are experiencing symptoms. Additionally, we are partnering with 180 of our community-based healthcare delivery partners, FQHCs, small independent practices in communities that are most affected, to ensure that we work with them to provide technical assistance in regards to increasing the opportunities for telemedicine and ensuring that if they require technical assistance in generating lists of patients to reach out to who have chronic illnesses, to make sure that they are up to date on their medications, make sure that they are refilling their medications, that we do that. And lastly, I will say that in this phase, we are working with our community-based partners, with our elected officials, to do teletown halls in multiple languages, again, to maximize the way in which we reach people directly with life-saving messages. In the next phase of our response, we will obviously need to implement both low threshold, low touch testing, and tap into the innovation that is occurring with regards to testing for COVID-19. I think none of us would dare say that testing has been what we have needed it to be. In this current phase of mitigation, it doesn't play as big of a role. We are highlighting the fact that we want providers to limit use to making treatment decisions. But as we move towards the containment phase and accelerating the deceleration of number of new cases per day, certainly testing will be critical for us, and we are looking at ways in which we can do that testing while preserving our personal protective equipment. And there is some innovation on the horizon, and I'm excited to see that come to fruition. One of the things that we are also actively planning, which dovetails with our equity plan, is ensuring that we make it as easy as possible for individuals and their families to isolate in place when they do develop symptoms and when they are exposed to the coronavirus, and the importance of providing wraparound services that will make it easy for individuals to remain in isolation. Again, services related to food, related to housing stability, related to childcare, all of those things that heretofore we have perhaps taken for granted as a city, but that have been acutely brought into light with regards to the challenges that many of our families have in following and adhering to our guidance. And then with regards to the scaling back of social distancing measures, I think that we've been very clear that we will need to employ a very measured approach to ensure that we minimize the degree to which we see a resurgence of the coronavirus in this. I think that would be, I think, the biggest disservice to this response is in terms of taking our social distancing measures off too quickly and then seeing that resurgence. With regards to, excuse me, our forward planning, we are obviously actively and anxiously looking ahead to vaccine production, but being very realistic that the most optimistic measures that I've seen are at best a year and a half in front of us. And so similarly, there are lots of studies going on, experimental treatments around what can be helpful for COVID-19, but obviously we have not seen anything really hopeful that I can see. And so we are actively preparing as we are preparing currently, but for the next couple of months with regards to the potential overlap for the flu season and, you know, the potential scenarios of still seeing these two viruses circulating at the same time and needing to ensure that we have sufficient personal protective equipment and all of the healthcare capacity for that eventuality. So right now, you know, I remain cautiously optimistic. I think that New Yorkers have demonstrated they are an incredibly resilient group, that we have amazing grit to not in any way, shape, or form let ourselves get down in light of really daunting measures, and that as we move forward with putting into place lifting social distancing measures, that we will need our partners, both in academia, both in healthcare delivery, to ensure that what we put in place is something that can make sure that there is no resurgence in our cases. And I want to be also mindful that our world will never be the same, that we in public health have a fundamental role to play in shaping our future new normal to be more just and equitable, that the data that has shaped our response must also be the data that makes us as a city stronger in surfacing and addressing inequities that have contributed to unimaginable loss of human life. So I want to thank you all, and I wish that I could be there in person, and that the work that is in front of us is work that will continue at least into September, and who knows how much further. So again, I want to thank you all, and I look forward to feedback from this gathering. So thank you all very much.
Thank you, Commissioner Barbeau. What a pleasure to have you amongst us. Now, our presentations were riveting and informative. Unfortunately, we don't have time for live questions, but we promise you one thing, that we have amassed all the questions that you have sent, and we'll send them to the right speaker, and we will post them on our website at CUNY SPH under our COVID page for our grand rounds today. And I want you also to remember to join us next week at the same time. We have Dr. Michael Merson, the former director of the WHO Global Program on AIDS, and amongst our faculty, Professor Jim Sherry will be moderating. Professor Bruce Lee will be talking about modeling, and our dear distinguished scholar Kathleen Crivero will talk about her previous experiences as well. Please join us next week at 2:30 same time, and visit our website if you would like to follow some of the answers to your questions. It's been a great pleasure to host this session, and thank you for your attendance and your participation. Thank you all very much.
Thanks.
Thank you, Scott.
Thank you, Dean. It was excellent.